everyone. Today my topic is tips and tricks of unstable fractures of trochanteric and subtrochanteric fractures by PFN. We will only talk about the surgical details. Then introduction. Cephalomedullary nails are commonly indicated in paratrochanteric and subtrochanteric fractures. There are 4 intertrochanteric fractures which are called unstable fractures. One is the reverse obliquity fractures, transtrochanteric fractures, and fractures with large posteromedial fragment with loss of calcar buttress, and IT fractures with subtrochanteric extension. These nails used in the trochanteric region are classified as pyriform portal nails. They are straight in the epinail, and trochanteric portal nails, they are angulated 4 to 6 degrees according to their manufacturers. And surgical procedures, it starts with preoperative planning. The mandatory are the X-rays. We'll take X-ray pelvis with both hips to know the neck shaft angle and medullary canal diameter, and to plan for whether the nailable or plate. And the affected hip is in lateral view, and we know the anteroposterior displacement and also bowing of the femur. And traction views are indicated if necessary. Patient is having more combination, and we'll go for the traction views. Rarely patient with 4 or more number of fragments. In younger people, it may need CT scan. The instrumentation are the following, and also positioning. Patient is positioned in supine position on a fracture table with the affected limb is in adducted to 10 to 15 degrees, and the chest is adducted to 10 to 15 degrees, and keeping the unaffected limb on the abduction and flexion, or only adduction with extension. And reduction, during reduction, very gentle traction, and followed by tying the foot end of the plate, then followed by internal rotation. If there is any excess of traction, it can lead to overhanging of the pelvis to the same side. It may cause difficulty during the making a portal to the entry and portal, and causing varus angulation, and leads to failure of the surgery. And for the draping, we will extend the sterile field up to the and above up to the iliac crest region, and 3 stitches with nylon sutures. This is to prevent towel clips. They are coming in between the lateral views. They will cause difficulty in viewing the pictures in lateral views. And multiple folds of towels should be avoided at the site of nail entry. This may cause drifting of the nail towards the lateral aspect, causing the varus entry nails. And fluoroscopic images during the surgery, they are AP and lateral views and true lateral views. And the true lateral views and lateral view, in lateral view there is a overhanging of the posterior aspect of the greater trochanter will be seen. In true lateral view, the head, neck, and also shaft of the femur, they are within the same line. The incision is planned according to a line drawing vertically from the anterior superior iliac spine down, and along the shaft of the femur is the center. It approximately 2 to 3 finger breadth above the greater trochanter will make a 3 centimeter incision, and cut the gluteal fascia and split the gluteus medius muscle. And the entry portals, they are making the entry portals. There are various devices. One is the 2.5 mm, 2.5 mm K-wire, 2.5 mm guide pin. Another is there are various companies, they are manufacturing fossa finders with steam and pin 4 mm, and also bone awls. And the entry point is modified medial trochanteric portals. The cephalomedullary, as we discussed, pyriform fossa, lateral greater trochanter, or modified medial greater trochanter, depending upon the design of the implant. We have to know the design of the implant before using it. The modified intertrochanteric portal this is the posterior aspect of the femur, which is showing the pyriformis fossa, and this is a 4 to 5 mm anterior to the pyriformis fossa usually entry, which corresponding to the center of the head and neck of the femur. And the another thing is to confirm make the trochanter into 3 parts by making a line, that is the anterior line, middle line, posterior line, and anterior 1/3, middle 1/3, and posterior 1/3. The junction of the anterior 1/3 and posterior 2/3 is usually the marking for the entry point of all the nails. This is the entry point, and always we have to check during the surgery after the CM images, after the AP. In the AP view, just middle to the tip of the trochanter, and in the lateral view, it is in the middle or in the posterior aspect. In the true lateral view is the most important to put the screws in the center of the head of the neck, which is the most deciding part of the surgery. The causes of varus position in nail entry is patient limb position, soft tissue mass, and operative drapes, and trajectory of the reamer and during reaming, and gradually enlarging the hole in the lateral aspect of the greater trochanter, which leads to the varus malpositioning, and high loads are impacted on that and leading to failure of the implant. And varus and valgus angulation, it can be assessed intraoperatively by CM images. If you draw a line from the tip of the trochanter to the center of the head of the femur, usually it corresponds to the center. If it is below, it is called varus. If it is above, it is valgus. Varus is not acceptable. And while doing the reaming, we have to maintain the reduction, and also the proximal reaming over the guide pin, usually by keeping the fracture reduced by external or internal means by using the steam pin or K wires, we have to make it reduced during the reaming. The usual reaming is 1 to 1.5 millimeters above the depth of the nail, but beware of the anterior bow of the femur. And always use the nail insertion in a manual mode, and we should not hit it with any hammer, because if we are touching the nail and if there is any difficulty in passing the nail inside the medullary cavity, then we have to check with the CM in the distal aspect, and we'll see whether causing any impinging on the anterior cortex of the femur or not. If it is hitting on the anterior cortex of the femur, the nail portal is wrong. So if you want to take it to the, if there is any difficulty in passing the nail or we are not able to correct the angulation, we have to use the two methods, that is the lateral, blocking the lateral with the 1/3 tubular plate or any plate, and make a entry medial to it. If there is if these plates are not available, we will nibble the bone on the medial aspect, will pass the K wires. And placing the proximal inferior screw is the first one we will do. And what I will do is, I will make in port, I will make guide wire passing up to the shaft of the femur, then I will put another guide wire over the limb. Then I will see whether these two K wires are, these two wires, guide wires are tallying or not in the AP view. If they are tallying well, this is the trajectory of my screw is going to be put. Then I will give the incision, then I will put a dent over the trocar, and I will pass the 4 millimeters of guide wire, so that the bending of the guide wires during the insertion, it is, this complication will not be occur. While doing reaming, sometimes there is a brokening of the K wires are possible. This complication prevented by reaming with the 4 millimeters. Then if the patient density of the bone is very high, then I will go with after 4 mm, I will put a guide wire and will ream for the 6.2 mm, then followed by 8 mm. These are the reaming one, and also always check the AP lateral and true lateral views during that one. And always, as per Dr. Ramkumar Reddy sir said, tip apex distance should be maintained for the inferior screw, and it should be always less than 25 mm. For the proximal screw, I will follow the same, the 4 mm guide wire, 4 mm drill bit I will use as for the distal locking, then followed by guide wire placement, then I will ream it and put the screws. The distal screws, to eliminate the distraction at the fracture site leading to non-union or implant failure, always release the traction before putting the screws, and check for any mal-rotation, and check for any mal-rotations. Then give the incision, always place the sleeves over the surface of the lateral cortex of the bone to prevent slippage of the screws during the insertion. Take home message: take extra care for preoperative planning, positioning and draping, and accurate imaging, that is AP lateral and true lateral views. Always reduce the fracture first, and the entry point modified medial trochanteric portal is the entry point. Maintain the reduction while passing a guide wire and reaming till the complete fixation of the fracture. Aim for the tip apex distance less than 25 millimeters. When in doubt, use a longer nail. Thank you.
Thank you, Ramesh, finishing in time and excellent presentation. Now I request Dr. Kaulay to present memento. Now I would like to invite